welcome to the deep dive. Today we're focusing on a really vital topic, especially if you're prepping for the MSRA, Upper Gastrointestinal Bleeding.
Absolutely. It's a common emergency, something everyone needs to be comfortable with.
We've got some detailed revision notes here, and our plan, our sort of mission, is to distill that down into the really high-yield stuff you need to know.
Make it clear, concise, and hopefully memorable. We'll try and weave in some memory tips, too.
Exactly. So let's get straight into it. Upper GI bleeding. Fundamentally, what are we actually defining here?
Yeah, so simply put, it's any bleeding that starts in the gastrointestinal tract, proximal to the ligament of Treitz.
The ligament of Treitz. Okay, that's the key anatomical landmark then.
It is. It's that suspensory ligament right at the duodenojejunal junction, basically where the duodenum meets the jejunum.
So it's the dividing line, upper versus lower GI tract.
Precisely. And like we said, upper GI bleeds are a common medical, gastrointestinal emergency. You will see them.
Right. Got the definition. So what actually causes these bleeds? What are the main culprits we should think of first?
Well, the most common one, by far, really, is peptic ulcer disease. That accounts for something like 50% of cases.
Wow, half of them. Okay.
Yeah. And the next big one is esophageal varices. They often present a bit differently, maybe with darker red blood.
Okay, ulcers and varices. Are there sort of broad categories we could think about for the causes?
You could think about it like this. You've got things that directly damage the lining, like ulcers, esophagitis, gastritis, duodenitis.
Like a direct erosion or inflammation?
Yeah. And then you've got issues related to increased pressure in blood vessels, which is what happens with esophageal varices, often linked to portal hypertension.
That makes sense. Two main mechanisms. So beyond ulcers and varices, what else is significant?
Definitely need to consider esophagitis and GORD. Gastritis, that inflammation of the stomach lining, can be acute or erosive, duodenitis too.
Right.
Portal hypertension itself is a driver. And unfortunately, gastric carcinoma, stomach cancer, can present this way.
Okay. And then there's the Mallory-Weiss tear.
Ah, yes, Mallory-Weiss. That's the one often linked to severe vomiting or retching. You get this linear tear at the gastroesophageal junction.
And that tends to be bright red blood, right? Haematemesis.
Typically, yes. And we shouldn't forget duodenal ulcers, particularly the posterior ones.
Why posterior specifically?
Because they can erode right into the gastroduodenal artery. And if that happens, you're looking at potentially massive bleeding. Really serious.
Okay, posterior duodenal ulcers, high risk. Got it. Our notes also list some rarer causes worth mentioning.
Yeah, worth being aware of them, even if they're less common. Things like angidysplasia, abnormal blood vessels, hemobilia, which is bleeding from the biliary system, like the gallbladder, bleeding disorders, of course, like low platelets or being on anticoagulants.
Sure.
Then there are specific conditions like Osler-Weber-Rendu syndrome, that's hereditary hemorrhagic telangiectasia.
Right, the fragile blood vessels one.
Exactly. Aortoenteric fistula, a connection between the aorta and gut, GVE, or gastric antral vascular ectasia, sometimes called watermelon stomach.
Stomach, okay.
And pseudoxanthoma elasticum is another rare one.
That's quite a list. Any way to maybe group those rarer ones to help remember?
You could think about the mechanism again. Angidysplasia and Osler-Weber-Rendu are vessel problems. Hemobilia is biliary. Fistula is structural. Maybe linking them to the system helps rather than just a list.
Good tip. Okay, let's shift to risk factors. Who's more likely to get an upper GI bleed?
Well, unsurprisingly, a lot of the risk factors tie back to those main causes, peptic ulcers and varices.
Makes sense.
So generally speaking, risk increases with age. Alcohol excess is a major one. And of course, NSAID use, non-steroidal anti-inflammatories.
Right, the NSAIDs. They reduce the protective prostaglandins in the stomach, don't they? But don't reduce the acid.
Precisely. So the lining's more vulnerable. Other big ones, being on anticoagulants, chronic liver disease, chronic kidney disease. There's even an association with lower socioeconomic status. And critically, for peptic ulcers, Helicobacter pylori infection. That's a major risk factor.
So a real mix of things, lifestyle, underlying conditions, medications. What about the overall picture? How common is this, and what's the outlook like?
It's actually much more common than lower GI bleeding, about 4 times more common.
4 times, wow.
Yeah. In the UK, the incidence is roughly 1 per 1,000 people per year, and it's more common in males than females.
And the prognosis?
Well, despite everything we can do, the annual mortality rate is still around 10%.
10%. That really underscores how serious this can be, even though it's relatively common.
It really does.
Okay, so let's talk presentation. How does someone with an upper GI bleed actually look? What symptoms and signs should trigger alarm bells?
It can vary quite a bit. Common symptoms include abdominal pain, maybe epigastric, maybe more diffuse. Then the classic bleeding signs, Haematemesis, which is vomiting blood.
Can be bright red or coffee ground, right?
Exactly. Bright red suggests active, ongoing bleeding, usually more worrying. Coffee ground vomit looks like, well, coffee grounds, it's older blood that's been altered by stomach acid. It often means the bleeding might have stopped or slowed.
Okay. And then Elena?
Melena, yes. Those black, tarry, really foul-smelling stools, that's blood that's been digested as it passed through the upper GI tract. Very characteristic.
And sometimes fresh blood per rectum, hematochezia.
Though less common with upper GI bleeds.
Less common, yeah. Usually suggests a very brisk upper GI bleed if it happens, or a lower source. Other symptoms can include feeling dizzy, lightheaded, maybe even fainting, syncope, or pre-syncope.
Due to the blood loss, presumably.
Absolutely. Unexplained weight loss could be a red flag, especially thinking about malignancy. Features of liver disease like jaundice, maybe difficulty or pain swallowing dysphagia or duodenophagia.
And confusion.
Confusion can happen, yeah, particularly if there's underlying liver disease causing hepatic encephalopathy.
And what signs might we pick up on examination? Key things are signs of shock. So, hypotension, low blood pressure, tachycardia, fast heart rate, cool, clammy peripheries, maybe confusion, chest pain due to poor perfusion, signs of dehydration, pallor, looking pale, reduced urine output, oliguria.
Okay, classic shock signs.
Yes. And you'd specifically look for signs of chronic liver disease, jaundice again, gynecomastia in men, ascites, spider naivety on the skin, caput medusae around the umbilicus.
Right.
You might feel an abdominal mass or enlarged lymph nodes suggesting a tumor. And obviously, assessing their GCS, their level of consciousness, is vital.
So it's a broad picture, but you're really looking for those direct bleeding signs, the haematemesis, the melena, alongside signs of hemodynamic compromise, shock.
Exactly. Assessing severity early on is critical. How much blood have they lost? How shocked are they?
And in the history, what are the absolute must-ask questions?
Definitely ask about previous GI bleeds, how much, how long did it last, alcohol intake, critically, all medications, especially aspirin, other antiplatelets, NSAIDs, steroids, anticoagulants. Ask about recent severe vomiting or retching thinking Mallory-Weiss, and you absolutely need to do a digital rectal examination, a DRE, to check for Melena or hematochezia.
Essential. Okay, we suspect an upper GI bleed. What investigations do we need?
The number one investigation is the upper GI endoscopy, the OGD. The timing depends on severity, but it's crucial.
And blood tests.
Full blood count, looking at hemoglobin for transfusion needs, and platelets. A venous blood gas, a VBG, can give you a quick HB level.
Use the left front.
Very. Then group and save and cross-match blood at least 2 units initially, and follow your local massive hemorrhage protocol if needed. Coagulation screen, INR, PT, APTT to check clotting.
Okay.
Liver function tests, especially if there's any history suggesting liver issues. Renal function and electrolytes urea is important here. A raised urea can indicate a more significant bleed.
Right, the urea can be raised disproportionately. Any other tests? ECG, imaging.
Yeah, an ECG is wise. Check for any cardiac ischemia or arrhythmias, especially in older patients or those in shock. Imaging. Well, a chest x-ray is useful.
To rule out perforation or aspiration.
Exactly. Or pleural effusion. Abdominal x-ray is less helpful for the bleed itself, but might show perforation or obstruction. An ultrasound abdomen can look for liver disease, ascites.
And urine output monitoring.
Crucial. Often needs a urinary catheter, especially if they're shocked, to monitor fluid balance accurately.
So back to the OGD. You said timing depends on severity. What's the general rule?
Ideally within 24 hours for most significant bleeds. But if it's severe, ongoing bleeding, or the patient is unstable, it needs to happen much sooner, emergently.
And it's both diagnostic and therapeutic.
Yes, that's the beauty of it. You can see where the bleeding is coming from: an ulcer, varices, a tear, and often treat it there and then. Clipping, cautery, injections.
Okay. Are there definite criteria for who needs admitting and getting that early scope?
Yeah, generally older patients, say over 60. Anyone with witnessed haematemesis or melanina or hematochezia, anyone showing signs of shock, hemodynamic instability,
Makes sense.
known chronic liver disease or previous varices, and significant comorbidities like serious heart disease or cancer. Those patients need to come in and get scoped promptly.
Right. Okay, we've got the diagnosis or strong suspicion. How do we manage these patients? What's the overall approach?
It needs to be structured, Prompt. The key aims are stop the bleeding, resuscitate and stabilize the patient, and treat any complications. And, as we said, endoscopy within 24 hours is central.
And you mentioned distinguishing between variceal and non-variceal bleeding management.
Yes, the approaches differ significantly in some aspects.
Okay, let's start with the immediate resuscitation, the ABCDE approach.
Absolutely fundamental. A, airway. Make sure it's patent. Consider intubation if GCS is low or risk of aspiration is high, especially with haematemesis or encephalopathy.
B, breathing.
High flow oxygen. Aim for SATs above 94%. Listen to the chest for aspiration.
C, circulation. This feels key here.
Hugely key. Get wide-bore IV access, 2 large cannulas minimum. Consider central access if needed for monitoring or infusions. Start fluid resuscitation immediately if shocked crystalloids usually. Rapid boluses.
And bloods.
Get all those bloods we mentioned, FBC, UNEs, LFTs, coag, group and save, cross-match, VBG.
And blood transfusion.
Yes. Transfuse blood if indicated by HB level or ongoing bleeding. Use O negative if you need blood urgently before cross-match is ready. Aim for an HB target usually above 80 GL, maybe higher, like above 100, in patients with known ischemic heart disease. Follow massive hemorrhage protocols if needed.
Continuous monitoring, too.
Definitely. Cardiac monitor, regular blood pressure, pulse, SATs, urine output monitoring via catheter.
Okay. D, disability.
Check GCS. A sense for confusion, encephalopathy. Avoid sedatives if possible, as they can cloud the picture or worsen breathing. Check blood glucose.
And E, exposure.
Full examination. Look for those signs of liver disease, malignancy, source of bleeding, any injuries. Keep the patient warm.
Are there specific drugs given during resuscitation besides fluids and blood?
Yes. If the INR is high, especially if they're on warfarin, give vitamin K. Consider fresh frozen plasma, FFP, if INR is significantly prolonged, say over 1.5, or fibrinogen is low.
Discuss with hematology, maybe.
Always good practice, especially if considering things like prothrombin complex concentrate, PCC, for reversing anticoagulants other than warfarin. Platelets aren't routine unless counts are very low, or bleeding persists despite other measures.
And always involve the GI bleed team early.
Absolutely crucial. Get the gastroenterology or surgical team involved as soon as you suspect a significant bleed.
Okay, now let's dive into the specifics. Variceal bleeding management following NISD guidelines.
Right. For suspected or confirmed variceal bleeding, the key things are start a vasoactive drug like terlipressin.
What does that do?
It constricts the splanchnic vessels, reducing blood flow into the portal system and lowering portal pressure, which helps control variceal bleeding. There's a standard dosing regimen, usually 2 mg than 1 mg QDS, but check for contraindications like severe coronary artery disease.
How long is it given for?
Usually max 48 hours, sometimes up to 5 days. Stop once hemostasis is achieved.
Okay. What else for varices?
Prophylactic antibiotics are vital. They reduce mortality and the risk of spontaneous bacterial peritonitis, SBP. Usually give them for about a week.
And endoscopy.
Endoscopy is key for treatment. For esophageal varices, the primary treatment is variceal band ligation.
Banding them off.
Exactly. For gastric varices, particularly certain types, endoscopic injection of tissue adhesive like N-butyl-2 cyanoacrylate, basically medical glue, is often used.
Glue for gastric varices. Any risks?
Yes. There's a risk of the glue embolizing, traveling elsewhere in the bloodstream, which can be serious.
Okay. What if banding or glue doesn't work?
If bleeding is uncontrolled, the next step is often a TAPISES procedure, transjugular intrahepatic portosystemic shunt. It's an interventional radiology procedure to create a channel within the liver to bypass flow and lower portal pressure significantly.
Right. TPS is a rescue option. And you mentioned cautious fluid resuscitation.
Yes, critically important in variceal bleeds. Over-aggressive fluid resuscitation can actually raise portal pressure and increase the risk of rebleeding. So, resuscitate to maintain perfusion, but be cautious.
Got it. Now, what about the non-variceal bleeds? Like ulcers?
Again, endoscopy, OGD, is first line for diagnosis and treatment. During the scope, if we find active bleeding, a non-bleeding visible vessel, or an ulcer with an adherent clot, these are high-risk features we treat them, usually with a combination. Mechanical methods like applying clips to the vessel, thermal coagulation, often with adrenaline injected first to slow the bleeding, or injection of fibrin or thrombin, again, often with adrenaline.
And repeat endoscopy.
Sometimes needed, yeah, especially if the initial view is poor or if there's a very high risk of rebleeding.
What if endoscopic treatment fails or they rebleed badly?
If they rebleed significantly after endoscopy and are unstable, the options are usually interventional radiology. They can perform angiography and embolize the bleeding vessel with foam or coils. Or sometimes surgery is required to directly oversew the bleeding point.
And medications. Stop NSAIDs.
Definitely stop NSAIDs and COX-2 inhibitors acutely. Low-dose aspirin for secondary prevention is often continued once hemostasis is secure, but it's a risk-benefit decision based on their cardiovascular risk.
Okay. Now, you mentioned risk scoring systems earlier, Glasgow-Blatchford and Rockall. Tell us more about those.
Yeah, they're really useful tools. The Glasgow-Blatchford score, or GBS, is great for initial assessment, often in A&E. It helps predict the need for intervention like transfusion or endoscopy.
What does it look at?
It uses clinical and lab parameters, HB, urea, systolic BP, heart rate, presence of melena, syncope, history of liver disease, or cardiac failure. Gender is in there too.
And how do you interpret the score?
A score of 0 is considered very low risk, and these patients might potentially be managed as outpatients in some settings. A score greater than 0 generally warrants admission. Higher scores, like above 6, indicate high risk. Interestingly, coffee-ground vomiting isn't part of the GBS.
Good to know. And the Rockall score?
The Rockall score has 2 parts, a pre-endoscopy score and a post-endoscopy score. The pre-scope score looks at age, shock, systolic BP and pulse, and major comorbidities. The post-scope score adds points based on the endoscopic diagnosis, like Mallory-Weiss versus ulcers versus cancer, and the stigmata of recent hemorrhage seen, like active bleeding, visible vessel, clot.
And what does Rockall predict?
It primarily predicts mortality risk. It's less predictive of rebleeding risk compared to GBS predicting need for intervention. Higher scores mean higher mortality risk.
Is there a mnemonic for Rockall?
Yeah, some people use ABCDE, age, blood pressure for shock, comorbidities, diagnosis, endoscopy findings, stigmata.
EBCDE, useful. Okay. Any other management points to cover? PPIs, tranexamic acid.
Right. So proton pump inhibitors, PPIs. Current CGN guidelines suggest not routinely giving high-dose IV PPIs before endoscopy unless there's a very strong suspicion of a peptic ulcer bleed, as it might mask some findings. But post-endoscopy for high-risk ulcers, high-dose IV PPIs are standard practice for 72 hours. Check local guidelines, though.
Okay. Tranexamic acid, TXA.
Not routinely recommended for upper GI bleeding. The evidence just isn't strong enough for benefit, unlike in trauma hemorrhage.
Good to clarify. What about H. pylori?
Absolutely vital. If the bleed was due to peptic ulcer disease, you must test for H. pylori and treat it if positive to prevent recurrence. Usually test after the acute phase.
And stopping anticoagulants, antiplatelets.
Generally stopped acutely during the active bleed, but the decision on restarting them needs careful consideration later, balancing bleed risk versus thrombosis risk. Always discuss with seniors and potentially hematology cardiology.
Makes sense. Anything else, like Sing, Stake, and Blakemore tubes?
Those are really rescue measures for refractory variceal bleeding when endoscopy and TPS aren't immediately available or successful. It's a tube with balloons to tamponade bleeding varices. Oesophageal stents are another rare salvage option.
Okay, so quite the toolkit available. We've stopped the bleeding. Patient is stable. What's the prognosis generally?
As we touched on, it really varies depending on the cause and the patient. That overall 10% mortality for new admissions is a key figure, but it's much higher, maybe 25–30%, if the bleed develops while they're already an inpatient for something else. These patients are often sicker to begin with.
And the Rockall score correlates with mortality.
Yes, a higher score, especially over 8, points to a significantly higher mortality risk. But prompt, aggressive resuscitation and early intervention definitely improve outcomes.
Are there specific factors that predict rebleeding?
Yes, older age, being in shock on admission, having underlying clotting problems, seeing pulsatile bleeding during endoscopy, and having significant cardiovascular disease all increase the risk of bleeding again.
Right. Finally, what are the main complications we need to watch out for?
Well, obviously anemia from the blood loss, collapse or cardiovascular compromise. Infection is a risk, especially aspiration pneumonia or SBP with varices. Hepatic encephalopathy can be precipitated or worsened in liver disease patients. Hypovolemic shock itself, and, as we know, sadly, death.
And complications from the endoscopy itself.
Yes, though generally safe, potential risks include aspiration, perforation of the esophagus or stomach, and bleeding related to the therapeutic interventions.
This has been incredibly comprehensive. We've gone from the basic definition right through causes, risks, presentation, investigation, detailed management for variceal and non-variceal, scoring systems, prognosis, and complications.
Hopefully that structured approach helps pull it all together for revision. Remembering those key distinctions, like variceal versus non-variceal, is crucial.
And thinking about those mnemonics like ABCDE for Rockall and just grouping causes logically esophagus, stomach, duodenum can really help it stick.
Definitely. Linking the risk factors to the causes makes it less about rote learning, too.
Absolutely. Remember to consider how those risk factors interact and how presentations vary, and how the scoring systems like GBS and Rockall guide those crucial early decisions.
They're tools to help clinical judgment, not replace it, but very useful.
For more revision resources, definitely check out passthemoutsra.com and freemelzer.com. Lots of great material there.
Good resources, yeah.
So, to leave you with a final thought, considering everything we've discussed, the diverse causes, the potential for rapid deterioration, what are the absolute non-negotiable first actions you must take the moment you suspect an upper GI bleed in a patient in front of you? Something to really cement those priorities. Thanks for joining us for this deep dive.